Okay, now another area in cervix cancer that has been exciting has to do with vaccines. And Dr. Herzog, you want to kick off this area?
Sure. So the exciting thing about vaccines has been the fact that we've been able to protect against infection with high-risk HPV types, which is a known and necessary causative agent for the development of cervical cancer, as well as some anal cancers and many head and neck cancers that we've now been able to identify. So the great thing was we had the vaccines that were kicked off, almost a decade ago, and we've been able to take the protection now from about 70% up to over 85% by adding additional valents. So we've gone from a quadrivalent, for example, or bivalent, all the way up to now 9 different types that are there. It is definitely an improvement. It is going to protect against other high-risk types. Remember that just 16 and 18, you're up to about 70%, and then you start adding in 31, 33, some of the other ones, you gradually get up, but it's a law of diminishing returns. You're getting only a few percent with each additional HPV epitype that you add. To me, though, the biggest problem is that we still have a bit of a lash back in terms of vaccination as a whole in this country, and especially with this particular approach. We've had a lot of stigmatization of the process, which has been, I think, very unfortunate in terms of the public health impact of this vaccine. So again, I hope that this renewed push will be helpful in terms of raising awareness and really bringing to the forefront the importance of vaccination. I'm not convinced it will. It's been relatively underused compared to what even the most pessimistic people thought. It's actually fallen below that. So it's been disturbing, in my opinion.
It's really, cervical cancer is preventable.
It's preventable.
Right.
I mean, we don't have many of those.
And the vaccine isn't being utilized, and the incidence rates are stable.
Right.
It's a no-brainer.
Yeah. But we do need to get it to, it has to be handled on a multifactorial. I mean, we have places in the world where cervix cancer is most prevalent, where they don't have any screening available.
Right.
And so I think, but it's impressive to know the efficacy of this intervention. I think the data that came out a couple years ago from Australia, showing the impact on the pre-invasive lesions that were seen in vaccinated cohorts where there was a stable population, remarkable. I mean, this stuff works.
Yeah.
But we don't do by genders. We don't do it in the right patient populations. And in the U.S., where we have a lot of resources, we don't even use it as well. But there's way more cases and where it can make a bigger benefit in all parts of the world where they don't have access. So it's multifactorial, but it's a shame to see such an effective therapy.
We've had a real
used.
poor uptake by the pediatricians too. They've not been allies in this.
They don't see the women that die of cervical cancer.
Let's look at the real issue here, right? Is that if this was a mandated vaccine, then we would have the uptake that we need. So really, this needs to be a mandated vaccine in terms of seeing the benefits and population health. I have young kids. You all have kids. I mean, in order for them to be able to get into school, they have to have their vaccinations up to date.
Exactly.
And until you make this a
Or at least
mandatory
an
vaccine,
opt-out.
or
But
opt out,
even
they don't
mandated
make a
with
difference.
opt-out is that it solves the funding problem.
Right.
Right. So the mandate really is overcomes the funding barriers.
Any other comments relative to vaccines?
I think we're all big proponents, and we'd like to see more of a public health initiative to increase the use.
Okay, were there any cervical cancer posters or presentations that were of interest at this particular meeting?
Prevention is certainly vaccination, but it's also screening. It's a two-tiered approach. And, screening, we used to think that the Pap test was the way to screen. HPV testing, you can test right on as all you guys know, you can test right on the cervix for the virus. And if the virus isn't there, there's no precancerous lesions, what we call CIN2 or CIN3, and there's no cancer. And it outperforms the Pap. So one of the things that's evolving, as you know, is this Athena trial. The Athena trial had 42,000 women. It tested 2 HPV 16 and 18 plus 12 other types. And they've basically shown, and now it's labeled, that you can do primary HPV screening. So there's really you know, what's the value of it? Even if HPV testing is better than the PAP, why do the PAP? What does the PAP add? And the answer is very little, and you can actually reduce the cost because you don't have to do all those unnecessary PAPs. So now there's one option, FDA approved, is to do primary screening, and if you have the virus, depending on the viral type, either do colposcopy and biopsy now, or triage to a PAP. It's really innovative, and I think that you guys talked about molecular testing in ovarian cancer. Well, now we can do molecular screening.
And the Athena trials also led to a joint statement by the ASCCP and the SGO
Yeah.
in terms of recommendations.
Yes.
So there's been interim guidelines issued as a result of the Athena
Led
trial.
to approval of HPV primary screening,
That's right.
and also now the societies are coming on board.
Right, and the
It's just-
NCC guidelines are essentially following that
Right.
same mandate.
Right. It's just simply more sensitive for picking up CIN2 and higher
Yep.
And it's
disease.
not really expensive either, so that's the good news.
Okay, well, then we